Welcome to the Health Daily Show. I'm your host, Chitra Nabat. Joining us today is Paul Markovich, President and CEO, Blue Shield of California. Paul, welcome.
Thanks for having me, Chitra. I thought you'd have a band introducing us.
Paul, we're a bit of a tight budget this year, but payers, you've got some deep pockets. Can a gal get a loan?
Well, for you, anything, yeah.
Paul, thank you. California.
Yep.
May soon be the fourth largest economy in the world based on different economic criteria like GDP growth. You run one of the largest payers with about $22 billion in revenue. What's unique and challenging about insuring your member population?
Well, we aspire to create a healthcare system that's worthy of our family and friends and sustainably affordable, which means you really truly have to personalize care for your members. And the biggest challenge is the size and diversity of both the population and the providers that serve them. So you have to do everything at scale, and you have to do it in a way that's personalized for not just a few thousand, but for millions of people and tens of thousands of providers. So that's the biggest challenge.
So then tell us a little bit about that differentiated approach to covering this diverse population at scale.
Well, it has to be high tech and high touch. You can't possibly understand all those needs and match them unless you bring healthcare into the digital age, truly automate things, and have that technology underpinning. But we also know that health gets driven a lot by just knowing people personally, that human touch. So, we've done things like create a comprehensive digital health record that people can access on their phone on the high tech side, and we also have a health advocate that can help people with more day-to-day life things like making sure they're getting the right meals and housing and the proper nutrition. So there's a lot of things that we're doing to try to make it both high-tech and high-touch.
A key stakeholder for you are the providers, facing a lot of headwinds, recessionary, increasing cost to care, pervasive cost to labor, depressed to negative margins. Many hospital system CEOs complain that payers want to cover less procedures or pay less. How do you balance growing revenue and margin and achieving your financial targets within this healthcare provider industry that's struggling to stay afloat?
Well, when it comes to us, we have a 2% pledge, or we will give back anything in excess of 2% of revenue on our net income. So for us, we're pretty clear about what our financial needs are. In terms of the providers, I would adopt the Rahm Emanuel philosophy of never letting a good crisis go to waste. The problem right now is that the profitability of a lot of providers is dependent on more services. And what we really need to do is, for example, pay hospitals to keep people out of the hospital, to really have the incentives aligned between the payers and the providers so that when care is more efficient, higher quality, better service, we all get rewarded and we all make money. But that's a pretty big shift from the world as it exists today, where more procedures, more heads in beds means more revenue and more profit.
That sounds nice and quote-unquote easy. Pay hospitals to keep people out of hospitals. Practically, operationally, how would you do that?
Well, we're doing it today in a couple different ways. In more of an HMO environment, we are creating risk pools that we share between the hospitals and the physicians to hit cost, quality, and service targets, which is working pretty well in what we call our Trio product, which is our fastest growing product. So we're actually doing it there in a way that's working. And then more on I would say on the PPO side, we're really shifting our payment models to population-based in primary care and more case rate with quality and service adjustments on the hospital side. So it's still scaling up. It's still relatively small, but it's scaling up quickly.
This word scale. A consistent trend for payers and providers is consolidation, and then also to providers and payers joining forces to become payviders. How will you drive growth?
Yeah, well, we are interested in scale as well in a number of different dimensions, because some of the investments that are required to support our plan and the system writ large in providers to do things like pay for value, they're expensive to do. And so being able to share in those costs is very helpful. So for us, we're always looking for smart ways to improve our scale. When it comes to the rest of the industry, it really boils down to whether or not this is going to be helpful. So for us, we're looking for scale because it can help our value proposition. It can help create a more affordable, higher quality, and improved service environment. If that's the case, I think it's worth pursuing. If not, I think others can pursue it sometimes for greater control, greater leverage in negotiations. That generally does not help.
But does that really benefit the patient, the consumer? Because some view payer consolidation not benefiting access and cost to care. There was a recent study by the American Medical Association showing Medicare Advantage that market lacks competition, which risks higher premiums, lower coverage, inadequate levels of patient care. Your thoughts?
Well, there's over 30 health plans that offer a Medicare Advantage plan in Los Angeles County alone. So I'm not familiar with that in my day-to-day job, but at the same time, I do think a lack of competition in any part of the value chain is not necessarily always beneficial to the consumer in the end, and I don't think consolidation is always beneficial. It's not automatically, consolidation is not automatically a good or a bad thing. The question is it actually improving and benefiting consumers at the end of the day and customers? If it's making it more affordable, more efficient, higher service quality, better clinical quality, then yes. If it's really just done to drive the benefit of the companies that have consolidated, then it isn't helpful.
Value-based care. How do we get to value-based care market adoption implementation faster and at scale? And where do you fit in?
Well, there's two things that have to happen. Payers have to be ready to do it at scale. And then providers have to be both willing and able to do it at scale. I mean, we're quite far ways along the curve in terms of our ability to do it at scale as a plan. But getting physicians and hospitals in particular to say, yes, I want to do that, and sign a contract to do it, and have the technology and the workflows on the ground, and just the financial sophistication to manage different types of risk arrangements, that's probably going to take longer. So to me, those are the things that are getting in the way of scaling rapidly.
Paul, let's talk about leadership. In career life, there are rules, codes, norms to how things are done. Where in your career and journey have you been a code breaker, and how did you do it?
I have been so passionate about bringing healthcare into the digital age. I get incredibly frustrated that we are still sharing information largely by fax and CD-ROM. So I have been pushing on that agenda for a while, against a lot of, I would say, parochial and intense resistance, because so many players, health plans, hospitals, other providers, electronic medical record purveyors, are proprietary about that information, and I think it needs to be much more ubiquitous. Still private and secure for the individual, but I think it's the members' data, and they need to have a comprehensive digital health record. And so I have been advocating for that, and we managed to get a digital mandate in California last year, passed and signed into law. So, and I don't want to stop there. I would like to see every American have a comprehensive digital health record that's real-time, cloud-based, and accessible on their favorite device.
Paul, thank you so much for joining us.
It's been my pleasure. And I'll look forward to the band next time.
Thank you.